Mechanical ventilation modes. By the end of this lecture, you should be able to compare volume preset and pressure preset assist control modes, explain the settings when starting a patient on mechanical ventilation, and decide which mode of ventilation is suitable for different ICU patients. The lecture assumes that you've already read the course manual properly. If you have not, you should read the chapter on mechanical ventilation modes before continuing with this interactive lecture. Before we go on with the lecture, I'd like you to think for a minute. If you were designing a machine to move gas in and out of the lungs, what would be the most important functions and features of this machine? In this talk, I'm going to cover the four most commonly available modes: volume preset assist control, pressure preset assist control, pressure support, and synchronized intermittent mandatory ventilation. Ventilator nomenclature is difficult because different manufacturers use different terms for the same mode. Here are some examples of different terms used by different manufacturers to describe volume preset assist control mode. Look at the ventilators used in your ICU and work out the term used for each of the modes described in this lecture. In volume preset assist control mode, you will need to set the tidal volume. The ventilator will, within limits, deliver that tidal volume regardless of the resistance or compliance of the lung. Inspiratory to expiratory cycling is set in a variety of ways depending on the ventilator. It's important to know how it is set in the ventilators used in your ICU. Inspiration can either be initiated by the ventilator or by the patient. However, the same tidal volume is delivered at the same time, regardless whether the breath is initiated by the ventilator or by the patient. The rate you set on the ventilator is the minimum frequency. If the patient's spontaneous rate is below this, the ventilator delivers sufficient control breaths to make up the difference. If, on the other hand, the patient's spontaneous rate is greater than the set rate, the ventilator delivers no control breaths. As well as setting the tidal volume and the minimum respiratory rate, you need to set the inspiratory time and inspiratory pause time. These may be set directly or indirectly. Longer inspiratory times result in improved oxygenation due to the longer time available for redistribution of gas. At the same time, peak airway pressures are reduced because more time is available to deliver the set tidal volume. On the other hand, shorter inspiratory times reduce the risk of gas trapping and intrinsic PEEP by leaving more time for expiration. The cardiovascular effects of mechanical ventilation may also be lowered by the lower mean intrathoracic pressure. Finally, PEEP also has to be set. As the tidal volume, inspiratory flow, and PEEP are all set, the airway pressure will vary as resistance and compliance change. It is, therefore, important to monitor the airway pressure. The tidal volume is unlikely to vary significantly unless there is a ventilator or circuit malfunction. The advantages of volume preset assist control are its relative simplicity, the tidal volume and minimum ventilatory rate are set, thus guaranteeing a minimum minute ventilation, and if properly set, it rests the muscles of respiration. The disadvantages are that it's not synchronized with the patient's breathing. Ventilator-initiated breaths may come on top of a patient-initiated breath. Inappropriate triggering, for example as a result of hiccups, may result in excessive minute ventilation. A fall in lung compliance results in higher alveolar pressure with the risk of barotrauma. And sedation is often required to achieve synchrony. Pressure preset assist control is essentially the same as volume preset assist control ventilation, except the pressure is preset instead of the volume. The inspiratory time or IE ratio are always set directly, and there is no pause time. Note that the pressure is applied to the proximal end of the endotracheal tube and is not necessarily the pressure in the alveoli. A constant pressure is applied to the endotracheal tube during inspiration. This results in a high initial flow, which falls during inspiration. As a result of this flow pattern, oxygenation may be improved. As the pressure is set and the inspiratory time is set, changes in resistance and compliance will result in changes in volume. It is therefore important to monitor the tidal volume. Its advantages are that it's relatively simple, avoids high inspiratory pressures, rests the muscles of respiration, and improves oxygenation. The disadvantages are that it is not synchronized with the patient's breathing, so a ventilator-initiated breath may come on top of a patient-initiated breath. Again, inappropriate triggering may result in excessive minute ventilation. A change in compliance or resistance results in a change in tidal volume, and it also often requires sedation to achieve patient-ventilator synchrony. Pressure-limited assist control with volume guarantee is known by a large variety of names, depending on the ventilator manufacturer. Some of these are listed on the slide. It's like pressure control, except the inspiratory pressure is automatically adjusted by the ventilator in order to achieve the set tidal volume. The maximum pressure that can be delivered by the ventilator is limited by the alarm limits. Pressure support. This is also referred to as inspiratory assist or assisted spontaneous breathing. In pressure support mode, all breaths have to be initiated by the patient, so it's only suitable for patients who are making sufficient respiratory efforts. In this mode, a constant preset airway pressure is supplied during inspiration, but at the same time, the patient is making an inspiratory effort. The tidal volume and inspiratory flow is determined by both the applied pressure and the patient's effort. In this mode, the ventilator switches from inspiration to expiration when the inspiratory flow decreases to a set percentage of the maximum inspiratory flow. This percentage is set using the inspiratory cycle off control. If the patient stops making an inspiratory effort, the flow will drop more rapidly, and in this way, the patient has control over the inspiratory time. The advantages and disadvantages of pressure support are shown here. It has the advantages that it is simple to set, avoids high inspiratory pressures, results in better patient-ventilator synchrony, and unloads the respiratory muscles. However, changes in lung compliance, resistance, or patient effort may result in changes in tidal volume. Studies in a variety of patients using a variety of ventilators suggest that pressure support of 3.5 to 14.5 centimeters of water are required to overcome the additional work of breathing due to breathing through the endotracheal tube, ventilator tubing, and demand valve. Patients who require pressure support of less than 6 probably do not require ventilation. In SIMV, the patient receives a minimum number of mandatory breaths, but is also able to breathe in between these mandatory breaths. These additional breaths are usually pressure support breaths. Unlike assist control, in which every breath is the same, in SIMV and pressure support, the patient receives two kinds of breath: mandatory breaths and pressure support breaths. The mandatory breaths can be volume preset breaths, pressure preset breaths, or pressure limited volume guaranteed breaths. They are synchronized with the patient's inspiratory efforts to prevent a ventilator-initiated breath coming on top of a patient-initiated breath. In SIMV mode, whether the patient receives a mandatory breath or a spontaneous breath depends on the exact timing of his or her inspiratory effort. If the patient triggers the ventilator close to the time a mandatory breath is due, the ventilator gives that mandatory breath. If the patient triggers the ventilator at other times, the ventilator delivers a pressure support breath. The ventilator does this by splitting up time into an SIMV period and a spontaneous period. In this mode, it's necessary to set the FiO2, the SIMV rate, which is equal to the mandatory breath rate, the SIMV period in some ventilators, the tidal volume or inspiratory pressure, the IE ratio or inspiratory time, the pressure support, and peak. The advantages of the mode include better patient ventilation synchrony and a guaranteed minimum minute ventilation, but it's a complicated mode and it may not rest the respiratory muscles. So what mode should you choose for your patient? In general, choose a mode that you're familiar with, but in certain circumstances, a particular mode may have an advantage. For patients who are largely apneic, assist control modes are probably best. Volume preset assist control, when control of minute ventilation is important, and pressure preset, when control of airway pressure is important. For patients taking intermittent spontaneous breaths, SIMV with pressure support may be best, while for patients taking regular spontaneous breaths whose condition is improving, pressure support may be the most suitable. In summary, each brand and model of ventilator is different. It's important that you know the ventilators in your ICU. Decide the suitable mode for each individual patient. Pressure support and SIMV enable better patient ventilator synchrony. And make sure you know the differences between volume and pressure preset assist control ventilation.